Well, thanks for your patience, everyone, and for making the time. It's a rainy day, and part of me just feels like crawling back to bed. But I'm glad you're here, you're present, and you're engaged, and that you made the time to join us in our regular faculty development webinars, so our biweekly webinars, which are really winding down for the year. We have our last one in May. And we have already started planning for the 2021-2022, some of the programming, some of our signature programming, and doing some things differently. So thanks again for joining us. I'm so lucky that we have Dr. Pinky Schultz with us today. She agreed to this back in last July. And no, I'm kidding though. She was quite excited to do this session for us. So Pinky, I'll turn the floor to you. I know you'll be telling us more about feedback models. And if you would like to do a more fulsome introduction, please go ahead.
Sure, I might tell you a little bit more about myself in just a little bit. So just to set this up, this idea of foundational, formative, fulsome, fruitful feedback. This is really meant to be a practical webinar on how to take feedback and leverage it for the really powerful educational tool that it can be. So I think most of you are attending from Queens. So just for those of you who aren't, we are providing this webinar to you from Queens, which is located on the traditional territories of the Haudenosaunee and the Anishinaabe. So this is what I hope by the end of this, you will have had an opportunity to have heard about the principles of feedback, just a little bit of theory, understand where it fits with competency-based medical education, contemplate some of the challenges on giving feedback, and explore some of the practical solutions to giving feedback. So really pretty practically oriented webinar. I have another wish. In addition to you having an opportunity to have heard all these things, I do hope that we will have a chance for some interaction, either through using the chat function, which Claudiana and her team are nicely monitoring for me, but then you can also actually speak and throw ideas out into the audio ether. I think I have about 35 minutes of sort of prepared content for this, so that hopefully will give us time to have some interaction as well. So I think the first question always when someone is going to provide a webinar or faculty development for you is, well, why would I even want to listen to this person? So I was adding up the number of years of precepting that I have under my belt, and a distressingly large number of years. So lots of opportunity within that to provide feedback for learners. I was also lucky enough to be part of the core implementation team when we rolled out competency-based medical education in our Department of Family Medicine. And feedback is such a component of CBME that I feel like I had the opportunity to learn a lot about feedback then. And as a result of that, do a number of faculty development sessions on feedback. So what I want to present to you today are some of the things from reading about feedback that I've gathered and put into play during all those years of precepting, but also I've learned a lot from other people when I've done these faculty development sessions. So hopefully that'll be a part of what today is, as well as people just sharing ideas of what's worked for them and what hasn't when they've been giving feedback. So I do have a bit of experience with this. I hope that I'm not going to come across as biased. I'm not making pots of money being involved in the medical education realm. I don't have any conflicts of interest, but I do have a bias. I am pretty committed to competency-based medical education as being a good way to train our trainees. And given feedback is an essential part of this, I'm pretty positively predisposed to feedback. So that would be my bias as I talk to you about feedback. So I want to first start, we were playing around to see if this heat map would work. I want to first start by understanding for you, when you signed up for this webinar, when I've asked people before, well, what did you get out of this? What were you hoping to get out of this? These are kind of these three buckets that people tell me about. So if you can, we're going to do a heat map by having you go up to the top of your screen, and you should get this little drop down menu. And then there's this annotate button. So if you click on annotate, that will pull up another little menu. Go on over and find a stamp that you like, click on that and grab a stamp, and whichever one, just put little tick marks beside which of these buckets you are hoping that you might get from today. And you can certainly choose more than one if you want to choose more than one. Okay, so that's great that we've got an interest in a number of these things. So making feedback effective, kind of building this into your busy lives as clinicians. How do you actually find the time to do this? And then what happens if you run up against resistance, if people don't really want to listen to this great feedback that you're giving them? Perfect. Are there, if anybody wants to just speak out, were there any other big buckets or aspects of feedback that you were hoping we'd cover today? Hopefully this will feel okay. Okay, perfect. All right, so I am gonna just get rid of this now, and we will move on to the next slide. So this is the little bit of theory to this webinar. So I'm gonna just talk a little bit about feedback and how does it tie into competency-based medical education. So the first thing is when people say to you, well, this isn't rocket science. In fact, when we talk about feedback, the original meaning did come from rocket science. So it was that idea of launching off this rocket, using evaluation to figure out where was that rocket going, and then either reinforcing it to get to target or correcting it if it was off target. So when we think about that, and then we think about competency-based medical education, we have some of those exact same goals in mind. So we are going to assess with a goal in mind. For the rocket, it's getting it to that moon, to that planet. For the resident, it's getting to them to be that independent, competent physician at the end of training. So we've got this goal in mind. We're going to use data to determine if they're getting towards that goal. And if they get off track, ideally, like with the rocket, you're going to pull them back on track as soon as possible. Way easier to do it here than when you're up here in quite a significant way to get them back on track. If they're off track, you're going to use some specific actions to redirect them. And if they're on track, you're just going to reinforce that and you're going to boost that up to the next stage. So lots of overlap with what feedback was originally intended to describe and what we're doing with competency-based medical education. What I want to be really clear about, though, is when I'm talking about assessing using that context of feedback, I'm talking about something called formative assessment. So I think probably a lot of you will have heard these two terms within competency-based medical education, that we have low stakes or formative assessment, and we have high stakes or summative assessment. So low stakes assessment is that idea of you're just assessing a small little bit of performance. It's really meant to be much more this assessment to help improve learning. So much more focused on improving their learning rather than being an assessment of their learning, of what they know. And the parameter around this is that it's very meaningful. You're assessing meaningful bits of performance to help them improve. At some point, all those little bits of data have to be pulled together to make these so-called summative or high stakes decisions. So we're pulling together all of that data, we're determining a picture, a trajectory, and this is much more assessment with the focus of someone's learning than particularly meant to be building someone's learning. And the parameter of this, because it's very summative and high stakes, is that this has to be a very trustworthy process. For both of these, there's an emphasis on documentation in addition. So for the low stakes assessment, that documentation is to help us get all that data. So when the high stakes decisions are being made, we're doing that in an informed way. And that's why you'll be encouraged by program directors and assessment directors, document that feedback, document that feedback. That creates that meaningful data so programs can then make these high stakes decisions. And then obviously these have to be documented for that promotion trail. So when I'm talking about assessment in this context of feedback, it's really focusing on this formative low stakes assessment, assessing just a little bit of performance, meaningful performance, and really meant to be driving learning. So if we wanted to put this into a pictorial sense, and some of you will have seen this before, formative assessment, each one of those assessments is just one little pixel that you're creating in this digital picture, if you want to use this analogy of this resin. Each little bit of formative assessment is one of these little pixels. Ideally, we're creating lots of these to get a very well-defined picture of this person, and we're creating them over all of the competencies to get the whole picture. That's what a formative assessment is. Summative is going to be pulling that together to create that whole picture. So the formative assessment, you're generating those pixels, you're tying that to feedback. And then what you can rely on is that the programs are doing the work to have set up those meaningful experiences and have that system to do that collection, collation, that interpretation to make those high stakes decisions. So we are focusing on low stakes formative assessment with feedback. And in the CBME world, then, why are we giving feedback? We're giving feedback for learning. We're giving it for improvement, either by recognizing and reinforcing when people are on track and just boosting them up a little way, or if they're getting off track, we're doing it to correct and refine performance. So these two purposes for improvement for our learners. So that's why we want to give feedback. I think the other important thing is, okay, we want to give feedback. We want to have this be for someone's learning, for improvement. The other big question is, it takes two to tango, right? It's sort of, well, do residents want feedback? And the data on that is very clear. Lots of studies highlighting that residents want feedback. When they don't get feedback, they identify that that's a problem for them. And they will repeatedly say getting behaviorally specific feedback that helps them with performance is a hugely impactful thing for their learning. So they are engaged and wanting feedback. So we're bought in, we want to do it. Then this first question is, okay, how do I do that well? And that was that first little bucket of that heat map that then derailed us. Was I think a lot of people had wanted to hear about, okay, how do I do feedback well? If I'm committed to doing it, let's make it impactful and do the job we want it to do. So there's lots and lots of literature around this, lots of different terms, but it seems to come down to 7 key elements of ideal feedback. That it's timely, it's given frequently, it's relevant and focused, based on standards, digestible, and it's going to stimulate learning. So I'm going to go into each one of these bullet points in just a little bit more detail, and then I'm going to stop and see if anybody has any questions or other thoughts of elements of ideal feedback. So the first part of this is that it's timely. And we've already talked about trying to get this feedback done early on before someone gets too far off course. So ideally, you're going to give this feedback as soon as possible after the event, partly so you're capturing stuff early, partly because that's the time the details are fresh, both for you and for the learner. So as soon as possible after the event. There's 2 exceptions to that. One, and it all comes to do with people's attentional focus. So especially if you're going to be giving that constructive, corrective feedback, ideally, you're not going to do that if you're in a crowd of other people. You're going to find the time to be able to talk to that learner by themselves, because often when you're trying to correct people, sometimes people get a bit embarrassed by that, which will narrow their attentional focus, and they're not going to hear the feedback that you're telling them if they're in a crowd of people. The other is if there's heightened emotions. So if there is those either the embarrassment or anger or upset. Again, the problem for the learner is if they're in one of those states, their attentional focus is very narrowed and they cannot take in extraneous detail. So your feedback will fall on deaf ears. The other thing is if you're in that state, you are not going to give that feedback in the best way for it to be heard. So any heightened emotion, just wait until that's passed before you give the feedback. But ideally, otherwise, it would be timely. Ideally, also, it would be frequent, especially very early on in a skill development. So early on, those first little steps, they're very uncertain for learners. So the more you can reinforce what they're doing well, get them corrected if they're making some missteps, doing that frequently early on is very, very helpful for that early skill development. The other thing that ideally with this frequent feedback that you're doing is you're making it iterative. So you're building on something that you already gave feedback about, and you're commenting on them incorporating the feedback that you talked about the last time, and seeing if they kind of heard what you said to them, and showing them how it may be improving performance. And so that's why I have this little icon of a chalkboard. This is my very low-tech way when I was doing work in the clinic to remind myself of, oh, I gave so-and-so feedback on this last week. I want to make sure that if I see them do that again, I'm going to remember to give them feedback on this again this week. So lots of feedback, and ideally building on what you've already told them before, and continuing to grow that. Clearly, you want to make it relevant. If you're giving feedback about something that has nothing to do with their skill development, they're not going to listen. So just knowing what those essential competencies are. We almost all of us are working with EPAs. Certainly the CanMeds FM roles are relevant. So making sure you're commenting on things relevant for their development. And ideally standards-based. So we do rely on our preceptors as experts, and every one of us has our own mental map of what competent looks like. And we rely on that. But the reality is our mental map of what good performance is what our performance is. And sometimes clearly we're bringing our own biases into this assessment of this resident. So it is really good to know what accrediting bodies like the Royal College and the College of Family Physicians and the programs have determined with their milestones, that these are the institutional standards that we would like our residents to be meeting. So do know what those are, and if they're quite different than your own mental map, then try to incorporate the institutional standards. This is an important slide. So ideally, you're also having your feedback be focused. And there's three kind of big important parts to this. So the first is your feedback is focused on behavior, not the person. So if you start your feedback with those senses, I saw, I heard, I felt, that will help you make sure your feedback is focused on behavior and not the person. You want your feedback to be descriptive and not evaluative. So you don't want to, ideally, you're not saying at the end of watching this, I think, or you were, or I felt that. If you put that after the I felt that becomes an evaluative statement, which is hard for the person to change. But the descriptive stuff of what they're doing is something that they can change. And again, the more specificity you can give to this, the better. So for example, you might have watched a resident with a patient, and at the end of it, you could say something to them like, oh, I felt you were very attentive. I felt that you were very attentive. This is an evaluation of what you saw. It's not actually what you saw, it's how you evaluated what you saw. A better way of coming in that feedback would be to say, I saw you turn from entering data into the EMR, directly face the patient and make really good eye contact when she started talking about some difficult things in her life. That is focusing on behavior, that's describing what you saw, whereas that first sentence, although very positive, is an evaluative type sentence, which isn't as helpful for the resident to know what to continue to do. So focusing on behavior, being descriptive, being specific is the type of language you want to use with feedback. The other thing is making this digestible and not having people drink from the fire hose. The problem with drinking from the fire hose is they get a little bit of water in their mouth and the rest sprays all over the place and doesn't stick. And the way I remember this is to think about my end goal when I'm giving feedback is for that resident to improve. It's very easy to get caught up into saying all the things you want to say. But the reality is they can probably only hear 1 to 2 things with an individual session. So really focusing in on the key 1 to 2 things that are either going to reinforce and recognize what's being done well, using all that good language strategies we just talked about, or refining and correcting where they need to, where they're getting a little bit off track. So when you're inclined to want to tell them 5 things, just cut it back to 2, because that's probably about all they're going to be able to take in with an individual session. And the last thing is thinking about, okay, we want this to be for improvement. We want to have it stimulate learning. So this is this idea of pushing someone just slightly beyond their zone of proximal development. So if the blue circle is kind of where they're sitting now with their knowledge and skills, we want to push them just a little bit further out to this new area of skill development, a little bit past their comfort zone. So we're trying to do that. And one great way to do that is encourage them to make a commitment at the end of your feedback session. So you could tell them what you think the path forward for them is, but way better is asking them to make that commitment. So based on what we talked about, what do you think you're going to try next time? The bonus of making them make the commitment is, in order to do that, they have to think about what you've talked to them about. They have to synthesize that, and they have to put that into an action. And that process of synthesizing and putting it into an action will encourage them to really learn what you've talked about. The other great thing about this is it gives you insight into how they're processing things. So I really try and make myself not give them what I want them to do, but at the end, ask them what they think they want to do for this reason. And then the other thing residents love is if you have, between you and them, there's been this identified way to move forward. If you know of some great resources for them, just tuck that one in and give them those resources. So I want to just tie this together into a model that may make this easy for you to remember when you're working with the residents. So how many of you have heard of the strategy of the Mac sandwich when it comes to giving feedback? I think a lot of you have probably heard of this. This came out of McMaster. It's not actually a Big Mac. It came out of McMaster. But it was that idea that you would give people some positive, constructive, some positive feedback. Then you'd give them that constructive, corrective feedback. And then you'd end with some positive feedback. One thing I'm going to just point out here is I am deliberately using the word constructive for corrective feedback, and not that this is negative feedback. The old Mac sandwich was positive, negative, positive. It's important to get into the mindset that the constructive, corrective feedback you're giving them, that is also positive. That is not a negative thing to be giving them that. So I'm going to use this term constructive instead of negative. That's an aside. So back to the Mac sandwich. So positive, constructive, positive. The problem with this is, first off, our learners got pretty used to this. So they kind of knew, okay, they're going to tell me something positive at the beginning, but this is where the meat of the sandwich is. I'm not even going to listen to this. I'm just waiting for this to hit me, this meat of the sandwich. So part of it is most learners just stopped listening to this, but it also depended a little bit on the learner. If you have someone who is a bit hard on themselves, and a lot of our learners are, they don't even listen to the bread. They don't even listen to the positive stuff. They don't hear that reinforcing stuff. They just hear this. You may also have learners who are on the other end of the spectrum, very self-confident. They don't hear any of the meat of the sandwich. They just hear the bread. They just hear the positive stuff. So that's what we found out was happening with the Mac sandwich, was people weren't getting all of the feedback that we were talking to them about. We did get the Mac sandwich a little bit more sophisticated. At one point, someone talked about adding a pickle on top of the Mac sandwich. So the pickle was the commitment thing. So, you know, you've heard this feedback. What are you going to do with it next? So the pickle is still a good idea, but there's this new model that's out there around feedback that gets you by people not listening to some of the feedback that you're giving them. And that's this BID model. So the BID stands for label the behavior. So again, that good language that we talked to you about I see, I saw, I heard, I felt. So you're picking the behavior. The one or two things to correct or refine that you're going to comment on. You're then talking about the impact of that behavior. So how did these things impact them being able to do those essential relevant competencies that you want to be providing feedback on? And then the D part of it is, what are those next steps? based on this feedback, what do you want to do with this next? So this BID model, it incorporates all of those good aspects of feedback that we just talked about. It gets people past that negating listening to part of the feedback that they were getting into with the mac sandwich, and gets them committed to this next step. So the pickle stays, but this behavior impact stuff gets that feedback going in a better way for you. So that's, I just want to stop at this point and see if there's any questions so far that anybody has. And I'm not going to stop screen sharing because this whole technology thing has freaked me out today. So Claudiana, can you just see if there's any hands up or anything in the chat about any questions anybody has about this so far? And I'm just going to put these 7 elements back up for you so you can see if you have any questions or comments about other things that you think aren't captured in these elements that are a part of ideal feedback.
Sounds great. And it's a good crowd, so feel free to unmute yourself as well if you don't prefer to use the chat. So now would be a good time if you have any comments in terms of what resonated with you or additions or questions.
And if not now, Claudiana, people can also jot notes and think to the end too. I hope there'll be good time for some ongoing stuff. Anything right at this point? Oh, I see Lucy's hand. Yes, Lucy, yeah. Go ahead.
Thank you. I hope you can hear me. I'm having Wi-Fi issues, but thank you. This was an excellent first part. And if you could speak a little bit more. So I do have the experience, especially like in health sciences, right? Programs that students really just want to hear what's negative. So what did they do wrong? And they really do focus on that. And I find like many of them do fail to look at everything good that they do, and they get very defensive. So, yeah. And I really appreciate what you said is because they're so used now to the sandwich or Big Mac approach that I find sometimes they're not listening to all the great stuff that they're doing. So how do you get around that? Like what kind of other language can you use?
Yes. So
what's good too?
It's a great question. And I do just point out to them that it is really important for them as part of our self-assessment is we do look at both what we're doing well. So we know we don't have to put a whole lot of time or energy into that. And we also are able to start to self-assess about where we need to improve. So I do talk to them about the importance of being able to also see what you're doing well, because we want you to keep doing that or to grow and build on that. And the constructive, I change the language. I always change the language as soon as I hear them talking about negative. I do talk about constructive, and it is that building thing. The defensiveness, we'll talk a little bit about that in just a little bit, Lucy. But so I think it would be me also pointing out to them, it's important that you hear what you're also doing well, because you need to remember that to continue to do that. I don't know if that's helpful.
Very helpful. Thank you.
Okay. And we're going to talk about the hitting the brick wall and when you hit up against that defensiveness as well.
And Pinky, there are a few comments in the chat as well. Yeah. Stephanie saying, thanks for the BID model, Pinky. I always hated the Mac sandwich. Catherine is saying, my technologies is that, oh, Catherine, your mic is not working. I'm sorry about that, but I'm glad you're using the chat. I really like the 2 stars and a wish. I started with 2 things they did well and something I want them to improve upon, keeping it focused and specific. And then Dave is saying, interested in any specifics to feedback associated with less concrete skills. Example, challenging interpersonal interactions with other members of the healthcare team. It's a good question.
Okay, so I hope I'll get to that a little bit in the hitting the brick wall section of this. If I don't get to that, let's talk about that more if it doesn't answer your question, Dave, around that. The 2 stars and a wish is one, it is that idea, kind of grabs all those great ideas of not too much. So it's not drinking from the fire hose, you're focusing on some stuff to improve, some reinforcing if you can find that. So it's that same idea, whatever framework you want to make yourself focus on a few things, using all that nice behaviorally specific language, looking at impact, Yeah, the BID model was pretty new to me, but I found I like that more too, because it made me do all these good things about relevance and focused and digestible. So, but the 2 stars and a wish is a great idea as well. Okay.
Thank you. I'm going to read one more comment and let you go on, and then
Okay.
hopefully we'll have some more time at the end. Rick is saying, when I'm asking a resident to look at the patient instead of their computer, they're usually looking at their computer screen instead of at me. So that's more of a comment, I guess, rather than a question.
Yeah. Yeah. For sure. Okay. So let's swing it over to some challenges. And this is really me just starting to grab ideas I've heard from other faculty development sessions and things that I have found have been helpful for me. So I think the first thing is us. I think it's us getting ourselves into the right mindset of what are we doing when we're giving feedback, because that whole connotation of the old term negative feedback, so many people steer away from that. So there's 3 aspects of getting into the right mindset. There's the idea of thinking of yourself, and probably a number of you have heard this, but that idea of thinking of yourself as a coach versus a cheerleader versus a critic. And what I would really like you to think about is getting yourself into that mindset of being a coach. So when we think about the differences between these 3 ways of working with residents, I want you to think about when you're learning a new skill, and usually when we think about coaches and cheerleaders, we think about a sports analogy, but when you're learning a sport, the cheerleader is really nice. It's a very supportive role. It's a comment on general performance. It's almost, I've never heard a negative cheerleader. It's always positive. And it makes people feel good, but that's a temporary feel good kind of thing. It doesn't help with skill development. And remembering feedback is all about improvement. Whereas the coach, they see their role as, I am trying to improve this person to get them to be that best physician that they can be at the end of their training. I am going to comment on specific performance in that focused way, and I'm going to let them know what they're doing well. But I am also going to give them that constructive feedback in order to get them back on track and further along. And the impact of this is sustained. The critic, always providing constructive feedback. They may be doing it on a very specific way. They are giving that constructive feedback. It is meant to improve people, but the problem with the critic is it doesn't become sustained, because residents will stop listening or they'll avoid them. And so you don't get that sustained benefit. So you want to really get yourself into this mindset that this constructive feedback is helping this resident be the best physician they can be by the end of their training. And that takes a bit of discipline to make yourself remember that, and you're not just there to boost morale. The other thing is, I think sometimes with constructive feedback, people shy away from it because they feel like, okay, I'm also being asked to document this. If I document that there was a problem with this bit of performance, somehow I'm going to derail this resident's progression. But remember, you are creating a pixel, just a little pixel. And that pixel does not make the picture. It is when the program puts all that data together and sees, is there a pattern here? Is this a one-off? As long as it's not something egregious, is it just a one-off? And in fact, that's not the pattern. The pixel is not going to significantly change the trajectory of this resident's career. It is going to help them improve and not change, well, it's going to positively, hopefully change that trajectory. So remembering that when you're doing that constructive feedback, that for me has been really helpful with actually documenting where I feel there's need for improvement. The other thing is finding the time. So probably many of you have heard of SNAPs and 1 minute preceptor, but I find these really good techniques because we are super busy. And something that's going to take more time is something we're going to be less apt to do because we just don't have the time to do it. So the nice thing about both SNAPs and the 1 minute preceptor is that there's been some studies done that have shown that both of these techniques do not take any longer than the old technique of having the resident go through the full history, full physical exam, talk about their differential, and then what their plan is. So kind of that SOAP approach. So both of these really narrow down how much they talk about the actual history and physical findings. In the SNAPS technique, you're really having them right away summarize the case, key pertinent positives and negatives, none of the other information. So pulling them beyond that reporter model, really pushing them to get into that interpretive model. You're then pushing them to narrow their differential down, tell you why they narrowed it down the way they did to get to their provisional diagnosis. They can ask you a question, the two of you can plan management, and then it builds in this time for feedback. I tend to like the 1 minute preceptor. I just find it easier. So I don't even ask for so the first thing is, this is not something you're going to do with a resident you've never ever worked with before. For those residents, you're going to have some time where you actually come to rely on their history and their physical. But as soon as I know a resident, the first thing I'll do is I'll ask them for their diagnosis. And this is where, when I ask them, how did they arrive at that diagnosis, they're going to have to tell me their differential in that. They're going to have to tell me those pertinent positives and negatives for how they narrowed it down and came at their actual working diagnosis. This lets me diagnose the patient. This also lets me diagnose their clinical reasoning skills. Single teaching point, and then here's where the feedback comes in, that positive reinforcing feedback, that constructive corrective feedback, built right into the model. So these take the same amount of time, but give you these other benefits of building feedback in, and also being able to not only diagnose the patient, but diagnose this resident's clinical reasoning. So these are helpful models in a busy clinical world to actually find the time to do this feedback. The other thing is, and this is such a simple thing, but it was a great study that came out of the University of Alberta, where they looked at this was on written feedback. They did some natural language processing, and they looked at what words are followed by that good, behaviorally specific way of directing residents that we want to have in our feedback. And these 5 words: consider, suggest, try, next time, because it is very, very hard to use one of these 5 words and not follow it with behaviorally specific ideas. So these are great words to remember when you're trying to get yourself to do that behaviorally specific ideas for improvement or for reinforcing what they're doing well. Because I said so is the one example that does not fit with this, but all of these others, they're really helpful words to remember when you're giving feedback. So those are some suggestions for dealing with some of the challenges of giving feedback and doing it in a way that's helpful. And I just want to swing over to now, because I know we only have 10 minutes left, is what happens when you hit that resistance. So this is you splatting up against the resistance of someone who's not interested in listening to your feedback. So a couple of strategies with this. One is the idea of choice. And I think because choice makes people feel like they have a little bit of control, it opens their mind up a little bit to receiving this feedback. So if I'm working with someone and I know we've had a bit of tension, a little bit of resistance, I will ask them, what would you like feedback on? I don't blindside them then with me giving them something because I've seen something else that I want to give them feedback on. So what would you like to get feedback on? Well, I may add something if I see that, but I'm really going to look to make sure that I'm able to give you some feedback on this today. The other thing is the choice around timing. So when would be a good time for me to give you some feedback on whatever the situation is? I've put these 2 in red to remind myself to just talk about this. The first is when you give feedback, it's always really helpful to label it because sometimes residents don't perceive that what you're doing is actually giving them feedback. And the other thing is to bound that, because if someone just comes up to you and says, when's a good time for me to give you some feedback? The usual first thing is, oh God, here it comes. You know, I'm going to be getting something that but if you bound it, when would be a good time for me to give you some feedback on that encounter with this patient? It's a bounded thing, which feels less uncomfortable for people. And I've already talked about paying attention to where their attentional focus can be as broad as it can be. So you want to ask them when a good time is. They may have to be rushing off to something right after clinic, and so trying to give them feedback then, they're all distracted. But also if those heightened emotions are at play, you want to let all of those cool down a little bit. So choice is helpful for opening people's minds up. The other thing, and I hope this will get to Dave's question, is sometimes it's finding an in when there's been a bad outcome. And this is a process diagram that comes from a lot of the conflict management literature. And that's the idea of having people think about their intention, the behavior, and how that maybe got them to an outcome that they weren't intending. So, and because often the intention is really good. So, you know, what were you intending when you got into your interview with Mr. X? Well, I was really hoping to help them stop smoking. That's a great intention. So what I saw when I saw you with Mr. X was when he started telling you about his difficulties stopping smoking, you stopped him and steered the discussion towards the dangers of smoking. So this was the behavior. He interrupted and he steered him towards articulating the dangers of smoking. The outcome of that, so what I saw shortly after you did that was that the patient said, I'm not here to talk about stopping smoking. I just want my blood pressure meds. So the conversation shut down. So here you have this outcome. It wasn't a great outcome. This is maybe some of these softer skills around communication and motivational interviewing. It didn't go the way you wanted, but the intention was good. So if you start with the intention, that's a nice positive lead in into the conversation. And then you can get into that behaviorally specific, non-evaluative, descriptive behavior and why this outcome was the way it was. And then you can have this discussion, you know, so next time, there's that next time, what you might want to consider doing is letting him tell you why it's difficult and the two of you problem solving. There's some great resources on motivational interviewing that I can give you for this. So I find this intention behavior outcome a pretty helpful model to keep in my mind when we're seeing some of these bad outcomes. The other thing that I will sometimes do, not with all residents, but some, is when I keep bumping up against some resistance, I pull some ideas out of this great article in Medical Teacher that for learners about 12 tips for them of making best use of feedback. And I really focus in on tip 7 and tip 8. Instead of us pushing against each other, we need to be working together. So let's keep our common goal in mind. My goal for you is to be the best physician you can be at the end of your time with me, at the end of your training, and that's your goal. I'm assuming that's their goal. You can ask them, you know, what are you hoping coming out of your residency? We've got this same common goal in mind. So as I'm giving you this feedback, that's what I'm trying to do for you, so that you're working together instead of pulling apart. So those are just some strategies that I found helpful when I kind of hit that brick wall. And I'm just going to wrap it up now. So hopefully, despite the technical difficulties, you've heard about these principles of feedback, those 7 great elements of feedback: timely, frequent, focused, focusing on those desired competencies, making sure it's digestible, and stimulating that learning by asking them for that commitment. Contemplated some of the challenges of getting yourself and your learner into the right mindset, and then some practical solutions for giving feedback. So finding the time with one of these models that builds in feedback, thinking of that BID model instead of the Mac sandwich model, but keep the pickle part of asking them to commit, and then remembering those 5 great words. So next time you give feedback, I would suggest you consider trying these words, because they promote giving really behaviorally specific feedback. So with that, and with like 2 minutes left, I'm going to see if there's any questions. I'm going to ask you to think about committing to one thing that you'll try with feedback that's either new or you'll do differently as a result of the fairly one-sided conversation, which I apologize for, but as a result of the webinar today. So any final questions or comments that you're seeing in the chat, Claudiana, or people have hands raised?
As people think of maybe a question and a comment, I can just thank you, Dr. Schultz. This was quite informative because it combined so well, as you said, some of those principles and the theory behind feedback and using CBME as the example, but also the practicality, those tips and strategies that you provided. I'm sure everyone found those very helpful. So any burning questions? We have 3 minutes left. Or comments? I see a question in the chat. If there is no space for one-on-one time, like in ED, how would you give feedback there?
If there's no space, like there's just no physical space to do it one-on. So if it's positive feedback, most times learners are pretty comfortable with that. It can in fact evolve into a really nice teaching thing for other learners that are around. So I just get permission first. You know, I just wanted to tell you some great things that I saw you do with such and such. Is it okay if we do that in front of people? If it's more constructive feedback, I will just find the time to meet somewhere else with the resident or the learner. I really feel like people are not going to hear it. Unless I mean, obviously gauge your situation. Maybe this is a really well-established team and it's not going to be, it's not going to be anything that's probably going to be very embarrassing, but for the most part, I would make the time to have us meet somewhere else.
Hi there, it's John Hagan. I'm from Toronto. I recognize Dave Robertson there, but another surgeon. But I just have one comment is that what we started doing, and I don't know if others can do this, but we videotape all our cases. And then at the end of the day, we'll sit with the residents and go over the cases. And most of the cases, like 99% of the time, that they're amazing, right? And they see how good they are. They don't appreciate it at the time because they're a little anxious. And then, but every case, there's something you can improve on, right? And you can go over that and the principles that you've outlined, you know, like, what were you trying to do there? What were you thinking at the time and things like that. But you could probably adapt it to have video of them interviewing, their patients and things like that. It's very impactful, I find, for them because when they're doing it, they think they're not doing a good job or they're not doing it. But when you actually see it, it's amazing, and they really boost their confidence. But
yeah, thanks for that comment, John. That's really interesting because I also wonder if when they're in the case, they're doing that, they're so focused on that, again, that attentional focus for them to be able to hear some of the feedback you might be giving them in that moment is not as easily received as when it's more relaxed and you're watching after. So partly you can pick and choose and show them, so they're seeing themselves perform. And partly I wonder if it's their attentional focus is good then. That's a great technique.
Well, the other interesting thing is that you review it, like when you do the operative note, you've forgotten everything about the case, but when you actually see the video, they remember exactly what they were thinking and what they were feeling at the time. Like they relive it.
Yeah.
And so it's, and most of the time what they do is good, right? So they'll hopefully get some positive feedback. I think it's okay to do that again or whatever. Or if it's something, bleeding or whatever, they might, think, well, can I do it differently? But yeah. You remember exactly what they were thinking and feeling if you do it the same day.
Yeah, we used to do that in family medicine a bit but it was such a long thing that it was going to take a long time to do it. So we'd ask them to preview the tape themselves and isolate some things that they wanted some feedback on. And maybe you're going to pick and choose a few other different things as well. But it is a really nice way to kind of get back into that performance and be able to have the time to do the feedback. That's great.
It is 1 o'clock, so I'm mindful of everyone's time, but Dr. Schultz, thank you again for this brilliant session. You can read some of the positive comments and feedback in the chat as well, and how appreciative everyone has been of this session. And thank you to every single one of you for for making the time and joining us today. Despite the challenges we had, it was absolutely brilliant, Pinky. So thank you.
Well,
and so useful.
Thank you so much, everybody, for your patience. That was much appreciated with the technical difficulties. Anyway,
I think it validated our humanity.
Yeah, there we go.
You missed some of those comments, Pinky, how we felt more at home.
Oh, good.
Because it has happened to all of us.